Let's go ahead and get started. I wanted to go ahead and introduce myself. My name is Amy Greiner, and I am with Kingsview Partners Wealth Management. I am a financial planner and a certified financial planner, which means I am a fiduciary advisor, fee-based advisor. And my clients, I help them planning for retirement, especially those that are within 5 years to 6 months of age 65. So certainly if you are planning for retirement and need some help with that, I can absolutely help. And my contact information will be in the chat feature if you have any questions. But I want to introduce to you Keith Knabb. Keith is with Affordable Medicare Solutions, and that is a free Medicare planning agency. They have over 25 years experience, and they have a staff of 9 employees. And between those 9 employees, they have over 100 years of experience combined. They really are not a set it and forget it kind of agency. They are very high contact with their clients, and they're one of the top rated and highest awarded agencies in Georgia. And Keith personally does over 100 education events like this yearly and in this metro area. So I want to introduce you, Keith, and let you take the lead. Thanks, Keith, for doing this for us.
Thank you very much, Amy. It's a pleasure to be here today. Hello, everyone. My name is Keith Knabb. And if you're in the Gwinnett area, my office is in Suwanee, Georgia, not far from Amy's office. And we have been in business over 25 years now. And I guess the best way to describe us is that we are Medicare nerds. We love Medicare. We know the ins and outs. And we have thousands of clients. We're the largest Medicare planning agency in Georgia. But what I've done over the last 10 years is I've become the most prominent Medicare educator in Georgia. And we provide education to nurses, social workers, elder law attorneys, as well as consumers like yourselves. So I teach at all the major hospitals. I teach at conventions. And we record these events now that we're doing them by Zoom. So we have a library of materials at our YouTube channel. And Raquel is going to be monitoring the chat box. And she's going to put our YouTube channel in the chat box, as well as she's put our website address. All of our services are free. We're very unique. We don't set it and forget it. We're there year by year as your health changes. If you move, if you have one spouse that has different health conditions than the other one, we help with all of those life events. And that's very different than most Medicare planning agencies. So today we're going to talk about Medicare, really the story of Medicare. And the story of Medicare started in 1965, and I'm going to share my screen with you, and we're going to talk for about 45 minutes, and I'm going to leave time at the end for questions. But if you want to put a question in the middle of the presentation, go ahead and put it in the chat box, and if it's something that needs to be addressed right away, if I've said something confusing, Raquel will interrupt me, and we'll address that question. Otherwise, we'll just have about 10 minutes at the end for your questions. So I'm going to share my screen. And you'll see that it says 2020 Beginner's Guide to Medicare. Well, really, even if you're already in Medicare, this presentation is for you because it tells you how to manage and how to expect what's going on with Medicare. This presentation is for educational purposes only. I am not employed by Medicare. I always do this as a public service. And of course, complete information is at the federal website, medicare.gov, medicare.gov. No plan names, no company names or prices will be shared today, and additional education flyers are available at our website, amsplans.com. So go back in the Wayback Machine. We're way back to 1965. 1965, the government created the federal healthcare program called Medicare, as well as Medicaid. They did this because seniors did not have retirement healthcare at retirement. And so they would work and they would retire. And at that time period, people lived to be about 65 or 66 years old. So this was thought to be a short-term safety net. But what's turned out to be, this is a long-term program. We're going to have 25% of Americans, about 85 million people, are going to be under Medicare soon. But there's another program called Medicaid, which is for the low-income individuals. and we're going to have about 30% of Americans under Medicaid. Right now, it's about 22%. That also, Medicare is not the same as group health insurance. It's not the same as veterans benefits, but you can have Medicare alongside group benefits, alongside Medicaid. You can have Medicare alongside the veterans benefits. All those are very common. You cannot have Medicare with the Affordable Care Act. So if you're using the Affordable Care Act, you have to exit it and go into Medicare when you turn 65, or if you're disabled, and we'll talk about that. So originally back in 1965, they designed this program to cover people when they turn 65 years old. If you've been paying your taxes for 10 years, also your non-working spouse would be covered and also be covered under the Medicare eligibility. Some people raised their hands and said, well, wait a minute, you know, Joe got hurt. He was working at the factory and he got hurt. He's 52 years old. He's not going to be able to work to 65. What are we going to do? They created Social Security Disability Income Program. And when they did that program, they triggered Medicare to begin if you're disabled for 2 years, that you'll get your Medicare. And after the 24 months, the card just shows up in the mailbox. Some other people raised their hand and said, well, wait a minute, this person's not going to live 2 years unless they have health care. They've got kidney failure. They need dialysis. So if you have end-stage renal disease or Lou Gehrig's disease, which is very fast-paced, you're going to get your Medicare very quickly, around 4 months into your diagnosis. Now, with Medicare, again, it was designed in 1965, and in 1965, healthcare was completely different than 2020. Of course it was. Most things were done at the hospital. And as things were done at the hospital, like exploratory surgery, or they were doing testing or other treatments, Medicare thought, well, of course, hospital's the big thing. We're going to give that portion of Medicare away at no charge, called Part A of Medicare, which is your hospital and your rehabilitation service, your skilled nursing rehabilitation. Now, that is important because that Part A used to cover most of what healthcare spending was, but not today. More than half of Medicare spending today is on an outpatient basis. And Medicare created the outpatient portion of Medicare back in 1965 called Part B, and it attached a premium to that. They didn't know how many people were actually going to ask for that. Today, you need to have A and B if you're in full Medicare in order to have total coverage. And there's a premium of $144.60 for Part B, for your doctors, your outpatient treatments, your MRIs, etc. Things that are outpatient today is pretty amazing. You could have a knee replacement outpatient, a hip replacement outpatient. It's pretty incredible. Now, we're heading towards 2005. Well, in the year 2000, the Congress started looking at the number of baby boomers that were getting ready to overwhelm the Medicare system. We didn't want it to be overwhelmed, but they realized they needed to update the system, much like the group employer health plans had been updated in the 1990s. So they studied this and said, all right, we need to give seniors some new options, but there were about 35 million seniors that were in traditional classic, run-of-the-mill regular Medicare. And they also realized those 35 million voters. So the congressman did not want to upset those voters. That could swing an entire election, of course. So they said, we're going to make all of these new options that we're going to introduce in 2005 options. They're not going to force people to change. And if people want to stay, literally, if they want to keep their plan, they can. They will be able to stay under traditional Medicare and not be bothered. And so that's the original pathway of Medicare. I call it Pathway 1. And in 2005, they created the new pathway of Medicare, which is a modernized side, and that the program is called the Medicare Modernization Act. And that's where they introduced the optional drug coverage and also new programs called HMOs and PPOs under Medicare. But remember, Medicare started this in 2005, and they're going to do this over 20 years from 2005 until 2025. So this is important. Giving a 20-year, one generation, time to make these changes has been very, very smooth. There's not been perfect, but any little hiccups that happen are not wrecking the system. If you compare this to the Affordable Care Act, which was introduced in 2010, and in a 3-year period of time, everything was introduced, man, it really upset the apple cart. So it's an example of how the one side of the government, the Medicare, got it right completely, and the other side of the government really created a lot of headaches. So it's amazing, just within the same government, you could have two different results. Medicare is doing very well at this point. Again, we're going to need to back up, because before the government decided to introduce those new changes, insurance companies were watching what was going on. And insurance companies love to hear about little problems they can solve, and they created a set of insurance policies all over the United States. Different companies created different policies to repair the holes in Medicare. Little insurance supplements of a huge number of variety, so that in Washington state, it was different than New York or Georgia. And in the 1980s, the federal government said, this is crazy, we're going to standardize these. And they standardized them, but they made a mistake. When they standardized these programs, they used the alphabetical letter code system again. So now we've got people that say, well, I've got hospital part A, and I've got outpatient part B, and now I've got to get this supplement, and it's like an A or a B or a C. They shouldn't have done that. They should have used Roman numerals or something else. But they did, and that was a mistake that was made. And so you will have your Medicare card, and then you will, if you want to use traditional Medicare, you'll buy a supplemental plan called a Medigap or a Medicare supplement plan, and it'll have a letter code. Right now, the current letter code that's most used is called Plan G. And that's your second card. It lays silently in the background. It does not interact with your doctors or your hospitals. When you go into the doctor or the hospital, you're showing your Medicare card, your United States Medicare ID card. Your supplement lays in the background and is electronically notified through a clearinghouse. Whenever Medicare pays a claim on your behalf, it triggers for the supplement to pick up the rest of the bill. It's a very clean system. And then in 2005, the drug programs came along to make a third card. So now you have a 3-card system. You have your Medicare card, your supplement card, and your drug card. That's what happened over time. So when the government decided in 2005 to create new side of Medicare, a new system, they said we want it to be a single ID card, a 1-card system. Of course, you're still going to have your hospital Part A, and you're going to have to pay for your Medicare Part B, because that's your foundation of Medicare. But your drug plan is going to be built right in, typically, and you're going to get a lot of extra coverage. And you may have seen Joe Namath on TV recently saying, get your extra Medicare benefits with his big toothy smile. Well, he's talking about these programs. There's a lot of extra benefits. The government has relaxed the rules and increased the funding, and we'll talk about those extra benefits in a minute. But the hallmark of these programs, besides being a 1-card system, is this is where Medicare introduced networks. So if you choose an HMO plan, you are restricting yourself to a mandatory network. You're putting restrictions on yourself. If you choose a PPO plan, you're choosing an open access plan that allows you to either use the network or go outside the network and pay more money. When you go outside the network, you're protected though. You get the Medicare fee schedule, not some crazy pricing. This is very important, and I'm going to go over the differences. Oops, wrong way. So in my practice, and Medicare is also reporting this, I've seen this for 7 years, 50% of people at age 65 are choosing the traditional path of Medicare. Half of my 5,000 clients choose traditional Medicare. And then half now, over the last 6 or 7 years, are choosing the new plans. And they've been around since 2005, but it's really been picking up steam over these last 7 or 8 years. So Medicare has been reporting this also. And there's no evidence that either side is going to go away. They're actually kind of migrating towards each other in some of the designs. And Medicare is incorporating different features in both sides of the programs. We'll talk about that also. But this is really important. There's no right or wrong way, and I'm going to show you the right way to decide for yourself what is right. Because one spouse might want to have traditional Medicare, and the other spouse might want to have the new modernized side to get the extra benefits. So it's customizable for your situation. So how do you make these decisions? I love Clark Howard. If you've grown up in Atlanta like I have, he's a great consumer advocate, speaks in very plain language. And this is a screen I developed in his honor, basically, because Medicare is very, very simple if you don't overthink it. And a lot of times people do. So the first column is what doctor can I see? The second column is, what is this going to cost me out of my budget each month? And the third column is, if I get sick, how much is it going to cost me to get better? And then if you look at the left-hand side, it says supplement on the top row, and it says advantage on the bottom row. Well, it's even simpler that if you look below there, it says prepay or pay as you go. If you buy an insurance policy and you pay premiums each month to an insurance company, you are prepaying for your medical events. If you use an Advantage program, you generally don't have a premium each month, and you're going to pay when you need care. So let's talk about the top line. Under the supplement system with Medicare, you can see any doctor who accepts Medicare nationally. Now, not every doctor is taking new patients, so you have to ask, are you accepting new patients? So if they do, then you'll be able to see them with your Medicare ID card. With the Advantage programs on the bottom, you're going to use your network first. If you're under an HMO, which I generally don't use, but if you're under an HMO, you might even have to get a referral. But if you're, and that's a mandatory network, but if you're under a PPO plan, it's open access. In most plans, you'll just be able to go with no referrals and choose a doctor out of the network. And it's probably even a national network, so that if you travel or have a home in another state, a vacation home, you'll be able to use it in both places. But if you wanted to leave the network, you can also see any doctor that takes Medicare nationally who is willing to see you, who is accepting new patients. Now, the next column is, under the supplement side, is that you have to pay for a supplement. It's an insurance policy. The premiums run $150 to $250 per month, maybe even a little bit less when you first turn 65. And you're going to buy a separate prescription program. Nationally, they run about $33 per month. But here in Georgia, it's only about $20. So we got a good deal around here. And that is, about $1,800 or $2,000 per year you'll spend out of your pocket. With the Advantage program, you don't do that. Most plans have a zero premium, but you're going to remember that you're going to have to pay copays. So that's the third column. What is it going to cost when you get sick? Well, under the supplement system, if you go to the hospital, you're going to have 100% coverage under most circumstances, and at the rehab center also. For cancer treatments, nearly 100% coverage. Under the Advantage system, you're not going to have that 100% coverage because you're going to pay a copay. $5 to see the regular doctor, or $10. Maybe you're going to spend $30 or $40 to see a specialist, just like your work insurance. And if you go to the hospital, you might pay $300 per day for the first 6 or 7 days. After that, it's free. So you're going to pay money, but you're also going to have an out-of-pocket protection of about $6,700 in a year, so that you're not hit with runaway medical bills. But let's use me as an example. I'm not 65. I have regular health insurance. I have a $6,000 deductible on my health plan. I had to get my nose worked on and I had it fixed. I had to write a check because I had a deductible. So I wrote a check for $6,000. Then I got my nose fixed. Well, if I'd had a Medicare supplement, I could have bragged that I had a free nose because there would have been little or no charge for my nose. Under the Advantage plan, I wouldn't have paid any money monthly and I would not have a deductible. But that new nose might have cost me $400 in copays. So it's not a big deal. It's just, when do you pay? Do you prepay or do you pay later? Your grandmother taught you this. There's no such thing as a free lunch. It's pay now or pay later. Before you get excited about what plan you're going to subscribe to, though, look at the star ratings. These are the quality ratings. And each year, Medicare officially assigns each program 1 to 5 stars. If a plan gets a 1 or 2 star rating, that plan is in trouble. And that does happen. And people at those plans lose their jobs, I'm sure, because they, instead of getting a nice funding from the government, they get a reduction in funding. And if you're a 3, 4, or 4.5 star plan, you're going to get increased funding. And those are average or above average ratings. And rarely here in Georgia, we've had a 5-star plan. It's happened 4 times over the last 15 years. And those plans get extra special privileges and extra funding. So the companies are really focused on getting these star ratings, and they're good. They're objective. They rank them on vaccines, screening tests, on hospital readmissions, and other objective measures. It's a very, very good system. Probably could even be tightened up more. So we've talked a lot so far about the general Medicare side of what's going on both sides of Medicare, but really the largest topic today in the news, besides the coronavirus or politics, is the cost of drugs for seniors. And can you imagine if drugs were not covered for seniors today, how much uproar there would be beyond what we're hearing? So think back to 2004. There was no outpatient drug coverage under Medicare. It started in 2005. And they were late to the game doing this. So they didn't know how many seniors were going to sign up for drug coverage or how many drugs they were going to use. So the government was very afraid this might bankrupt the federal budget. So they put a lot of restrictions and certain breaks in the program to keep it from having runaway costs. And so it made a very confusing prescription drug program. I'm going to decode that for you and show you what you do need to worry about. But what happened in 2005 has been improved in 2011 and also again in 2020, we had an improvement. So they're going to probably improve it again in 2025. So this is how confusing the Medicare drug program can be. If you've never seen a drug program like this in your life, I can guarantee it. It can have a deductible. A lot of plans will have a deductible of up to $435 or no deductible on generic drugs. Maybe this deductible only applies to brand names, depends on the program. You get an initial bucket of money. This year it's $4,020. They're upping that to $4,050 next year. And then you have a phase where you used to have no coverage. It was a boogeyman called the donut hole or the coverage gap. And that's where the government said, look, you've run out of your initial bucket of money, you're on your own. And people were walking away from the pharmacy counters when they ran out of their drug coverage. They said, forget this, I'm not gonna spend $500 on a drug. I was only spending $20 for it, last week, and now you're asking me to pay more. So the donut hole has been shrunk, and it's not a bad thing anymore. And that's what happened between 2011 and 2020. Much less problems there now. And also you're protected by an out-of-pocket limit this year of $6,350. Next year it's $6,550. Well, they're going to have to start addressing that because that's pretty high. But they have, after that point, you have a catastrophic umbrella where you only pay a little bit for your generics, maybe $8.95 for brand names, or 5% of the cost of the drugs. And so this is important. If you're low income, you get to skip all of these rungs of the ladder and you immediately go to that bonus round of the catastrophic coverage. So low income people need to pay attention. If you have a friend or a family member that's suffering on the cost of drugs, have them call me and I can give them some advice on this. Don't worry about all of those details though. Once you've got your drug list and you know your favorite pharmacy, it's not hard now to go to the Medicare website. I do this free for my clients. We'll key in their drugs. If they're already in Medicare, their drugs are already in their online account. It gets populated automatically in there. And I can just check off which drug we want to use for next year. We put in the pharmacy, we hit go, and immediately it says, hey, there's 28 drug plans in your county. You don't need to look at 28 plans. It'll show you the right plan, the top 3 to look at. So it's very simple. And if you already have a current plan, it'll put that one at the top and then the right plan that you're supposed to be on next. So you can do this starting October 1st. You can do the drug comparisons. We do it for our clients, but you can create your Medicare account now. So you can go into medicare.gov. At the top right corner, you can create a My Medicare login. And so we do this for our clients. Even when you try to do it yourself, it's kind of confusing to understand some of the small differences between the plans, like how the deductibles work. And I'll explain that to you. It's not a problem, and it's a very effective system. But when people don't do this, when they don't do this process, it's a $720 per person average error per Medicare and research studies. It's incredible. $720 per person for a husband and wife, that's $1,440. $720 out of your pocket is $720 in the pocket of the insurance company or the drug plan. They have very little incentive to teach you how to do this because they're going to lose profits. Being a good consumer, like Clark Howard says, you're going to keep the money in your pocket. So let's go back to the low income people, because 20% of seniors who deserve extra help have failed to ask for it or failed to reapply if they were turned down previously. So low income, somebody may have lost a spouse. Maybe half their Social Security income is gone. Social Security will come in then and pay up to $33 a month to cover the cost of the drug program for that low income person. It's free. They'll just pay for the drug plan. And then if the person also has low enough income, they can also get extra help at the pharmacy when they pick up their drugs. So that if they were paying $200 a month for insulin and they get on this program, they'll pay $8.95 for it. It's a huge deal, a giant deal. There's other support. They're going to eliminate all the deductibles and donut hole and all of the those phases and let them go straight to the catastrophic phase. If somebody gets Medicaid, they automatically give them this. But if you don't qualify for Medicaid, you need to actually apply for it by calling Social Security or calling my office, and we'll walk you through it. Very important, especially for widows and widowers. Still, after all that, some drugs are too expensive. And a lot of the pharmaceutical companies that come up with these drugs, I have some people taking $25,000 and $30,000 drugs per month. They'll have a patient assistance program because they want people to use their drugs, because some of the drugs that were $25,000 a month 3 years ago now are $50 a month because they've recouped their research and development dollars. Some cancer drugs like Gleevec and other ones. So this is important. You can ask for patient assistance or chronic illness funds or foundations, and they'll have generally a reimbursement. You'll spend the money, you'll get reimbursed either monthly or annually for the cost to cover your portion of the cost so that you can get your drugs. I don't have a high cost medication, but I use generic drugs. And sometimes when you use Good RX, you'll find out that the Good RX price is cheaper than your health plan's price. So I'm a big advocate for Good RX. I use Good RX all the time when I do my drug reviews, because if I notice a drug is $10 or $12 and I look on Good RX and it's $3, I'll tell the client, use the Good RX coupon at the pharmacy, but you have to tell the pharmacist ahead of time, I'm going to use my Medicare drug card for these drugs, and for this one drug, I'm going to use my Good RX coupon. Tell that ahead of time because you don't want to make your pharmacist mad that they have to undo the billing. You want your pharmacist to like you. All right, so now we spent a good first 30 minutes talking about what's gone on in Medicare with the changes from 2005 until now. Well, this is now the modern innovations. The modern innovations, Medicare is now trying to innovate. They've done a lot of the major changes, but let's do some more targeting on modern innovations. Well, if you look at category number 1, preventive care, I don't think many of you would think that that was a modern innovation, but it was for Medicare. Medicare did not cover preventive care until 2005. And when they did that, they only tested it first under the modern HMO and PPO plans. They tested it from 2005 until 2010. And they realized that it worked pretty well. And in the Affordable Care Act, they had a little Medicare section. They said, hey, we're going to make preventive care cover everybody in Medicare. And I still today have doctors and nurses say that Medicare doesn't cover preventive care. It does a really good job. There's 27 items. But it took a long time for Medicare to add that on. But Medicare doesn't cover everything. If your doctor wants to order a few extra tests, maybe you'll pay a couple bucks, a few dollars for those extra tests. Not a big deal. Now, does Medicare cover, number 2, gym memberships? No, but Medicare has authorized and allowed the Medicare plans, if they want to provide you with a gym membership to LA Fitness or Ladies Workout Express, etc. And that has proven that people go to the gyms are using 30% less medical dollars than the ones that don't. It's a social event. We've had the pandemic, the gyms were closed, so they turned these into online classes, or they sent out things to do workouts at home. And the gyms are now reopening, especially after we get a vaccine, they'll all be back open again. Does Medicare provide dental, vision, or hearing? No. They're considering adding those things to Medicare, but right now Medicare is first allowing the HMO and PPO options to provide that. So a lot of the plans, when you see Joe Namath talking about get your extra Medicare benefits, he's talking about maybe $2,000 of dental care, maybe $2,000 of hearing aid coverage, maybe $250 of eyewear and free glaucoma exams. I mean, they're really substantial benefits. So why would they do those things? Because they drive down the cost of medical care. Periodontic infections in the mouth lead to other problems, even heart problems. Hearing loss leads to brain shrinkage. Vision problems, half of all glaucoma is found in a routine vision exam. So this is important, catching things early. Number 3, expansion of at-home services. We've seen a lot of the modern Medicare plans providing over-the-counter medical items delivered to people's homes for free. Sunscreen, vitamins, allergy medicines, antacids, a huge catalog of the same stuff you see at the pharmacy store. They'll just deliver it to your house and they give you an allowance, maybe $30 to $100 every quarter. And it's stuff that's in your medicine cabinet today. They're going to help you out with that and, and provide those medical items to you. Cotton swabs, lots of different stuff. But there's some other things that they're looking at, such as a lot of the plans are providing meal delivery to your home, that if you go to the hospital and come home, they'll deliver you 14 meals. A lot of programs are doing that now for an inpatient stay at the hospital, not outpatient. And some plans, about 1% of plans, have been looking at doing at-home care services like cooking and cleaning or bathing or dressing or other things like adult daycare payments. So there's been some small experimentation in some of the unusual areas. Even Uber and Lyft are soliciting companies to provide coupons that get paid to help people to do medical travel that's not emergency medical travel, but to drive you to the pharmacy or drive you to the doctor. But what's going to save Medicare, the big one, is number 4. 1, 2, and 3 are great, but number 4 is what's really going to keep Medicare solvent. Because 5 people out of every 100 people, so 5% of Medicare beneficiaries spend 50% of Medicare's dollars. So it's not everybody, it's just 5%. But still, other people get sick too. So let's talk first about care coordination. If you get a new knee or a new hip, or you go into the hospital for COVID and you go home, you might get a care coordinator that calls you and says, hey, I want to make sure you got your oxygen. I want to make sure you're doing your follow-up visit. I want to make sure you're finishing your cycle of care, finishing that circle and that cycle, because if people drop out of that cycle, they tend to have higher medical bills. If they'll finish the cardiac therapy, they'll use their oxygen, they'll tend to get better, and that way won't be on claim anymore. That's care coordination, and the hospitals started pioneering that first because they get penalized if somebody shows back up into the hospital a week later. So they have an incentive to help people stay out of the hospital. Plus, during the pandemic, you need to free up beds. But the bigger one is chronic illness management, because if somebody has 2 or more comorbidities, heart and lung problems, weight and diabetes problems, kidney and blood pressure problems, if you have 2 or more health issues, comorbidities, then your medical spending goes through the roof. It's documented. They know that's the trigger, 2 or more. So those people, they're lasering down, they're doing health risk assessments, they're identifying these people, and Medicare sends the companies extra funding for identifying those high-risk individuals so they can provide them with even more services, to for sure provide them with care coordination and a chronic illness manager to manage their diabetes or manage their cancer or manage their Parkinson's. So this is important. And Medicare is not doing this yet under traditional Medicare, but they will. They are studying it first under half of the members that are joining the Advantage system. So eventually all of Medicare will start doing these things, and these differences between the two sides will be gone. So how do you get into Medicare? The next topic we're going to go over is the enrollment periods, or election periods, they call them. And everybody gets lots of different chances to manage their Medicare. It's not a lifetime decision. It's not a one-time, you make a decision and you're done. You get to manage your Medicare using enrollment periods. For example, your initial enrollment period is 3 months prior to turning 65, and also the month of turning 65. So you can, if you're either being or awarded Medicare due to disability, when you get your Medicare card, you can start doing your initial enrollment. That's important, because that initial election happens to everybody, but if you're working, you don't need to use that necessarily. You might fall under the next category, which is called special election. Special election means I'm beyond my initial election and I've retired. I'm 70 years old and I'm ending my employment, or I'm moving. I'm in Medicare and now I'm changing where I live, my residence, or I've lost a spouse and we've lost some of the benefits or my income. Those are special events. At work, you call those qualifying events, like a birth of a baby or a marriage. under Medicare, there's special election periods. Now, everybody in Medicare gets the third one, which is called an annual election. That starts very soon, October 15th to December 7th. But we also get a preview period on October 1st. So they release the information for 2021 plans, for next year's plans, on October 1st. And then for 2 weeks, everybody looks at the information. I do a lot of reviews for my clients, but the Medicare website might find some errors. They fix the errors, and we go live, completely live on October 15th, where we can actually start doing applications that'll be effective for January 1st. So it's a very busy time in my industry from October 15th to December 7th. And you should do your annual review. You should contact us before October 1 to get on the docket for October. Everybody that's also in Medicare that has an HMO or PPO plan gets the last column, which is a new category that is January, February, and March of each year, the first quarter, that if somebody didn't do their annual review, or they did do a review and they made a bad choice, they get a mulligan. They get a one-time choice during January and February and March to fix their problem. So maybe they find out their doctor is not in their HMO plan anymore. Maybe they find out their drug's not covered, and they should have done their annual review. We would have caught that, but they didn't. And now we can fix it. We can fix it for February 1 or March 1, or the latest date I can fix it is April 1. So it's important. And if somebody is in trouble and has a problem, they need to call me, because I'm not allowed to tell people this, like to my own clients. I can't call them and say, hey, you didn't do your review, we need to do this. Medicare has a weird rule that prevents me from actually making that phone call. Strange, it's the government. Now, if somebody is low income or special needs, they get once per quarter, every 3 months, they can make a change. They get the most flexibility because they are under a special needs circumstance. Now, if you don't do these things right, there's penalties. There's, fines, basically. So if you use COBRA instead of using Medicare, that's a problem. So I have to teach human resource directors this information. A lot of times I'll have a 67-year-old retiring, and she's got a 63-year-old husband, for example, or vice versa. And you'll take spouse-only COBRA. COBRA on the younger spouse, the older spouse will go into Medicare. And that's fine. And then I will help migrate the younger spouse as they turn 65 into Medicare. Or if they don't take COBRA, we can use the Affordable Care Act. But if you use COBRA instead of Medicare, you can end up with a lifetime penalty under Part B, the outpatient portion, a very severe penalty, and under Part D, the drug penalty, a very small penalty. And also, high income earners face a separate high income backdoor tax called IRMA. I have another video on our YouTube channel about high income and IRMA, and the definition is an individual with more than $87,000 of income, or a husband and wife with more than $74,000 of income. Low income people don't pay these penalties, or if they become low income later, the penalties are removed. Now, I know you're all feeling like you're Medicare experts. You've learned a lot, and there's going to be a 100-question test on the next screen. No, I'm kidding. There won't be a test, and there are no prizes. But Medicare doesn't cover everything. We know that Medicare is trying to cover more. They're doing a lot of innovation. But if you want a full permanent dental program that is there year by year and is not a gift benefit, but a permanent benefit, you can buy dental insurance. Of course, Medicare covers critical events like a heart attack, a stroke, or cancer, but you may want to have extra benefits during that trying time. You may want to have a $10,000 payment to help you with extra costs. Medicare does not pay to bury you. I've had that question before, and it doesn't. So you have to have your own life insurance or burial policy. But the big one is the last one, home care. Home care assistance, such as having somebody come and cook and clean or bathe or help you go to the restroom, that's home care assistance, and Medicare doesn't cover that. Also, Medicare does not cover the costs of assisted living or nursing homes. Medicaid will cover a little bit of some of these things, but in order to get that covered, you will need to either have three things. You can have a long-term care insurance policy, so talk to Amy about that. You could have veterans benefits if you or your spouse was a veteran, called aid and attendance, Or you could have the third category, which is the large pile of money category, which means sell the beach house, something like that, because it's going to cost you $4,000 to $6,000 per month for an assisted living home or for somebody to come care for you at your home. Medicare provides up to 100 days of skilled nursing rehabilitation. That means you're not stabilized. That means you've come out of the hospital. So maybe you need to have a week on oxygen or monitoring or something, or learning to use your new hip or knee. That's short-term rehabilitation. Medicare covers that. And even though it says it covers up to 100 days, it's rare for people to really get more than 20 days, unless it's like a stroke or something super bad, a burn or something else. So Medicare now has a way that they authorize a certain number of days, 3, 7, 10, 14, based on your diagnosis. And those number of days reset for a new diagnosis. So if you had, a bad fall in 2020 and then in 2022 you have a stroke, your benefit has reset. Recap. Watching the time here, we're coming up on 45 minutes. There are two paths to take under Medicare, either the Advantage or Supplement, Medicare supplement side. And half of people at age 65 are taking one or the other one. And it's not a permanent decision. Don't let anybody tell you you're making a permanent lifetime choice. I will teach you about that. Medicare, of course, doesn't cover everything. We went over that. And review your plan every October 15th through December 7th. We do that for free for our clients. All of our services for our clients are free for Medicare. Remember that dual people that have Medicare and low-income Medicaid, or chronic illness or special needs people, they get extra privileges and extra plans. They get extra help under Medicare, and they can maybe make changes all year long. Very important. The next steps, it's always a process. So whether you're retiring or you're turning 65, you want to do this about 3 months ahead of time to apply and get your Medicare card. It takes about a month for them to issue your card to you. And then that gives you a couple months or a month to do some shopping and learning, finding the right plan, talking to your doctors, to your pharmacist, working with my agency, and we'll help you find the right plan. And we'll show you all the options. It's your customization. And then when your birthday or your retirement date comes, you're fine. But then again, remember, October 15th is time to double check and make sure you're on the right program. Last two slides I want to go over very quickly before we take questions and answers are concerning Medicare and the coronavirus. We're having a lot of good news lately on the coronavirus, but unfortunately, Georgia's still in the top 5 nationally. Our numbers are improving, but Medicare did a really good job. Back in March, they responded quickly. You would think it would be this big bureaucratic mess, and it wasn't. It was actually very quick. They approved that all the lab tests for COVID were going to be free. They had to create new coding for that. They also said that when these new antibody tests that came out, FDA authorized antibody tests, are also free. And they've also said that if somebody's in the hospital, you pay your normal costs for going to the hospital because it's a medical event. Under a supplement, it's free. Under the Advantage system, you'd have a copay. But a lot of the Advantage plans have been waiving and not charging the copay for going to the hospital if it's a COVID diagnosis, because we want people to go in and get better and also not to be spreading it amongst their community. But if you had to stay in the hospital because you didn't have a place to discharge for a day or so, they would also cover those charges. That hasn't happened as much lately because we do have bed availability in Metro Atlanta. There is some problems in the rural areas where we do still have hospitals that are near capacity, but it's getting better. Let's hope the fall continues in that pathway. The new vaccines, they're coming. I watched a video this morning that there is a very good chance the AstraZeneca vaccine will be available mid-October for healthcare workers, frontline caregivers, and the elderly, vulnerable, and then maybe for the rest of us by the end of the year. Very good news, and we're probably going to have 4 or 5 vaccines. Medicare has said all of them that are FDA authorized are going to be approved and then included in the immunization schedule, just like your influenza vaccine and your pneumonia vaccine. Very important and very good that they made that announcement. Now, a lot of the insurance carriers have gone also above and beyond, and they said, look, we're going to waive your cost for the doctor visits, waive your cost for specialists, for mental health care and telehealth care. Been a lot of great response from a lot of the companies, not every one of them. And some of the plans actually went back to March 1st and refunded people copays that they had paid. They went back. The insurance companies actually have excess money right now because a lot of elective surgeries have been put off. They took some of that money, and some of the plans have actually sent, I can't show you the logo, but I'll show you what it looks like. I actually sent you cloth washable face masks. And that's smart. Every plan should have sent out face masks right away to all of their members, but one primarily did that. Pretty smart. Give you two, you wash one, wear one, and maybe that'll keep you out of the hospital. Simple, effective solutions. Some of the Medicare supplement plans have also announced that they're going to keep rate stability. If you have a friend that's complaining that their rate has gone up recently, like a lot, they need to call me, because some of the major plans have given very good rate stability. Also, Medicare itself has given us special relaxation of rules. They extended one of the enrollment periods from the end of March until the end of June. We're expecting some extra relaxation potentially. We haven't been promised this for the annual enrollment period. So if there's a hurricane, if there's a bad flu and COVID re-outbreaks, then we're going to get some extra special help, I think, from the federal government. Really need to do that to take care of the seniors. My company is Affordable Medicare Solutions. There's our website on the screen. Remember, it's not just me. There's 9 of us here. We're extremely talented. If you look on Google and Facebook, we have hundreds of 5-star reviews. We're the largest and most award-winning Medicare planning agency in Georgia. And I am excited to help you or your friends, and there will be no charges for any of our Medicare services. We get paid through the system. Medicare authorizes whatever plan that you choose to pay us to service your plan. I'm going to turn this back over to the main screen. And Raquel, do we have any questions from our audience? How does Medicare work with hospice? Edward is asking a question. Medicare, it does not matter what side of Medicare you're in, traditional or modernized. Hospice is 100% covered. And hospice means you're going to have palliative care. So if you do want to continue taking some medicines like cholesterol medicines or other things, you might have to pay for some of those things that aren't necessary for your just being palliative care. But most everything under hospice otherwise is 100% covered. And it's very good. And we have some excellent hospice companies. I have one that I use that I know very, very well that is just spectacular. So if you know somebody that needs hospice care, call my office and I'll make that referral to you. Any other questions such as that? I encourage you all to go to our website. You can download there's a flyer on how to create your Medicare account, or you can go to Medicare and just play around with the website. But if you haven't created a Social Security account, you can do that first. The Social Security account is ssa.gov, Social Security Administration. That, though, won't let you create a Social Security account if your credit is locked. So unlock your credit and create your temporarily and create your Social Security account. And through that account, you can do a lot of neat things. If you're already in Medicare, you can create your Medicare account. And it's really, really effective. And we need our clients to have their Medicare logins, or we'll help them create those Medicare logins. Pretty good system that the government has made over these last 2 years. Thank you very much, everyone. I hope you learned something new today.